Now, I would like to request our madam and sir to take their seat and conduct the rest of the session. Thank you.
Honorable Director Sir, Vice Principal Sir, my respected teachers, senior and junior colleagues, beloved intern doctors and students, Assalamu alaikum. Today's journal presentation, study on serum creatinine in female diabetic patient. It will be presented by Dr. Maria Hussain. She graduated from this medical college, CBA 2007. She did her MPhil in Physiology from Mymensingh Medical College under Bangabandhu Sheikh Mujib Medical University. She has been promoted as Assistant Professor in Physiology in 2018. Now, I would like to Dr. Maria to come to the dais to deliver her presentation. Please, Maria.
Thank you, Madam. Bismillahirrahmanirrahim. Assalamu alaikum and good morning to all. In today's journal presentation, the title of my article is Study on Serum Creatinine in Female Diabetic Patient. This is the letter of acceptance to be the publication for the issue in July 2024. Introduction. Diabetes mellitus is one of the most common metabolic disorders of great impact worldwide. It is one of the major global health problems affecting 382 million people and accounting for 5.3 million deaths in 2013. By 2035, the number of affected people is expected to increase to 592 million globally. In the South Asian region, Bangladesh has the second largest number of adults with diabetes. Dyslipidemia, hypertension, and visceral adiposity are associated with diabetes, and these are the comorbid risk factors for developing chronic disease and cardiovascular disease. End-stage renal disease and diabetic nephropathy are mainly associated with renal disorders in diabetic patients. 25 to 45% of diabetic patients clinically develop diabetic nephropathy in their lifetime. Glycosylation of tissue proteins causes deterioration of the structure and function of kidney, which finally leads to diabetic nephropathy. In many countries, diabetic nephropathy affects 30% of all diabetics, which is the leading cause of end-stage renal disease. Abnormal renal functions like abnormal blood urea, serum creatinine, and microalbuminuria are some of the characteristic features of diabetic nephropathy. In uncontrolled diabetes, there may be hyperglycemia-associated abnormal increase of blood urea and serum creatinine. So urea and creatinine are the two important factors to find any abnormality in the kidney. Serum creatinine, when it alters, there will be more reliable reflection in GFR, whereas urea formation depends on factors like liver function, protein intake, and rate of degradation of proteins. So measurement of blood urea and serum creatinine helps in the early detection and prevention of diabetic kidney diseases and prevents the progression of end-stage renal disease. As renal complications are more common in diabetic patients, we aim to measure the serum creatinine levels in female type 2 diabetic patients and correlate this parameter with female non-diabetic patients. The findings suggest that increased serum creatinine is likely to occur in patients with diabetes with renal insufficiency, particularly when it is poorly controlled. So the aim of my study is to increase the level of awareness and understanding of serum creatinine level among patients with diabetes type 2, which will eventually lead to interventions to optimize treatment outcomes in them. Methods. It was a cross-sectional analytic type of study and my study period was from July 2016 to June 2017. And I did the study in Mymensingh Medical College. I took total 210 subjects, and they were grouped as group 1, that is control group, and consists of 70 healthy women of reproductive age, that is from 21 to 45 years of age. And in group 2, that is study group, consists of 140 diabetic women of both reproductive age group and postmenopausal age group. Age range, postmenopausal age is 45 to 70 years. Group 2 is again subdivided into Group 2A and 2B. Group 2A consists of 70 diabetic females of reproductive age group, and Group 2B, 70 diabetic female of postmenopausal age group. Inclusion criteria. For control group, women of reproductive age between 21 to 45 years of age. For study group, women of both reproductive age and women of postmenopausal age between 45 to 70 years were taken. Exclusion criteria. Age more than 70 years or less than 21 years, women undergone hysterectomy or receiving hormone replacement therapy, pregnant women, diagnosed case of hypothyroidism, Cushing syndrome, polycystic ovary, antipsychotic drug users, regular steroid users, those that have history of smoking, known case of any type of cardiac disease such as heart failure or myocardial infarction, any type of systemic illness such as tuberculosis, hepatitis, known case of malignancy, patients with thalassemia, hemophilia, known case of blood loss such as recent surgery, trauma or overt GIT hemorrhage, and acute infectious illness conditions were excluded. Persons showing disinterest were excluded from the study. Laboratory investigation. I did serum creatinine by enzymatic colorimetric method by photoelectric colorimeter. Normal value of serum creatinine, we all know, 0.6 to 1.1 milligram per deciliter or 53 to 97.2 micromole per liter in female. Results. The results were analyzed by using SPSS method. Data were expressed in mean plus minus ST, and statistical significance of difference among the groups were calculated by unpaired student t-test. Pearson's correlation coefficient tests were done to see the correlation between different parameters. This chart shows the physical parameters of the control and study group. Here we can see there is a mean age, height, body weight, BMI, systolic and diastolic blood pressure. If we see the BMI, we can see in the control group 1, the BMI is 25.34. Study group 2A, the BMI is 28.46. And study group 2B, the BMI is 28.86. This table shows comparative study of mean plus minus ST of serum creatinine between control and study groups by unpaired student t-test. We can see here the serum creatinine in control group 1 is 1.051 plus minus 0.25. Group 2A, the creatinine is 1.59 plus minus 0.67. And in group 2B, the serum creatinine is 1.55 plus minus 0.67. This table shows the statistical analysis of serum creatinine between the control group, between control group and study groups, and within the study groups by unpaired student t-test. Here we can see the comparison between group 1 versus group 2A. The mean difference of serum creatinine is 0.539. Here the t-value is minus 6.365, and it is statistically significant. In comparison between group 2A versus 2B, the mean difference is 0.04. Here the t-value is 0.370, and it is statistically not significant. This is a bar diagram showing mean value of serum creatinine in different groups. According to the above result, serum creatinine was increased in the study group, and the result is statistically significant. Serum creatinine remaining in control group female is within physiological range. Discussion. In this study, mean plus minus standard deviation of serum creatinine of control group reproductive female and study group diabetic female of reproductive age, that is group 2A, and diabetic female of postmenopausal age, that is group 2B, is 1.051 plus minus 0.25 milligram per deciliter, 1.59 plus minus 0.67 milligram per deciliter, and 1.55 plus minus 0.67 milligram per deciliter respectively. There was significantly increased serum creatinine in study group 2A in comparison to the control group, and the result is statistically significant. But there was no significant change in serum creatinine between study group 2A and 2B. The result is consistent with that of Mishra et al. This study proposed that serum creatinine levels were significantly increased with increased duration of diabetes. Impairment of urea and creatinine level due to increased blood glucose level indicates reduction in kidney function in diabetic patients. Metabolic changes caused by diabetes leads to glomerular hypertrophy, glomerular sclerosis, tubulointerstitial inflammation, and fibrosis. Due to this, there is large residual risk of diabetic kidney disease onset and progression. The study from Sangareddy district, Telangana, India was inconsistent with prevalence of creatinine impairment with diabetes mellitus. The study done in Nigeria supported this finding, which showed 30.59% of subjects with an average duration of diabetes 8 years and above shows impaired creatinine level. Similarly, study done in Brazil showed that serum creatinine impairment was associated with type 2 diabetes. The study from India Tertiary Teaching Hospital was inconsistent with prevalence of serum creatinine impairment. Shrestha et al. In 2008 stated that diabetes mellitus is the major cause of renal morbidity and mortality, and diabetic nephropathy is one of the major causes of kidney failure. After many years of diabetes, the delicate filtering system in the kidney becomes destroyed. Initially become leaky to larger blood proteins such as albumin, which are then lost in urine. According to Negri Lombas and Zamsheta, a recent study on data from NANIS-3 found that prevalence of severe renal impairment was greater for women than men. Herrera et al. In one of their studies stated that after menopause, the incidence of renal disease increased, suggesting that the loss of sex hormones contribute to the development and progression of kidney disease. A more recent study by Krupa has shown that estrogen helped to protect against kidney disease and may exert certain cellular effects on kidney because it can suppress the growth of scar tissue as well as effect of various growth factors which impact the kidney. These data are important because Herrera et al. Have found that the risk of development of hypertensive kidney disease is less common in women compared to men. However, this gender protective effect diminishes and tends to disappear with the onset of diabetes and menopause. There were some limitations of my study. The study was conducted with small sample size, so it may not be adequate to represent the total population, and a large sample size would have given a better result, and only females were taken. Because our data were obtained from a cross-sectional study, there is a possibility of a temporal association which makes it difficult to ascertain our conclusion. Longitudinal studies are needed to better characterize this relationship. Parameters were measured only once, and thus changes over time could not be evaluated. Serum creatinine is not the absolute marker to diagnose diabetic nephropathy. eGFR, estimation of protein in urine, and albumin-creatinine ratio could be done for early diagnosis and staging of diabetic nephropathy. Conclusion. From the present study, it may be concluded that serum creatinine is significantly increased in female diabetic patients in comparison to normal healthy female. It is also seen that type 2 diabetic persons are considered to have significant positive relation for increased serum creatinine. So prevention of type 2 diabetes mellitus by taking necessary steps like regular physical exercise, intake of healthy diet, and behavior therapy may help in prevention of type 2 diabetes mellitus related complications. Therefore, it is important to consider each and every postmenopausal woman to undergo screening test at a regular basis. As type 2 diabetes affects serum creatinine concentration in women significantly, specific health education strategies are needed in order to prevent the emerging cardiovascular, metabolic, and renal disease. Thank you all.
The journal presentation should have a format, and it should be according to a research methodology. So if I ask Maria, what were the general objective and specific objectives of your study? You didn't mention that, it is to be mentioned. So would you please tell me now what were the general objectives and subsequently what are the specific objective of your study? Number one. Number two, why did you pick up the women, diabetic women? Number three, as you had shortage of time and resources, you picked up the study design, the cross-sectional study. But it could be a case control study as well, and in other studies, the cohort study, as you mentioned as well. So that could be another point. And my another questions may be a very silly questions to Dr. Rad. Why we people are picking up creatinine as the important parameter for kidney diseases? Why not the other parameters? Thank you very much.
Thank you, sir. Sir, the general objective of my study is to assess the level of serum creatinine amongst the three groups of females that I have taken and to compare the level of serum creatinine in between them. Three groups হ্যাঁ
একটু মেনশন করতে হবে যেহেতু তুমি একটা জার্নাল প্রেজেন্টেশন দিচ্ছ এখানে এই দুটো জিনিস অবশ্যই থাকতে হবে জেনারেল অবজেক্টিভস স্পেসিফিক অবজেক্টিভস এন্ড রেশনালি অফ দ্য স্টাডি ব্যাকগ্রাউন্ড
জি জি স্যার জি স্যার আমি এক্সটেন্ড করতে পেন দিই একটু পেনটা নিই And sir, my second question was, sir, why I took females? Because sir, in previous studies, it was found that serum creatinine was comparatively more in females rather than males. So that's why I took interest in that. And as far as there is a reference here that we can see that the prevalence of severe renal impairment was greater for women.
যে ক্রিয়েটিনিন মেয়েদের বেশি থাকে
Thank you, sir, for your nice question. At the same time, I am very much hopeful and thankful to the Department of Physiology, especially Professor Dr. Shahnaspati Madam and their team, to invite me here to say something in front of you all. I hope you all will tolerate me as I will discuss in this regard.
very much pertinent.
Thank you, sir, for your nice query. Why we have chosen the serum creatinine value to assess the renal function. Nowadays, the creatinine is very easily available and it is very feasible as well and cost effective. So it is in generally taken as the measure of the kidney function. Also, we know that already Dr. Maria has stated here that the creatinine value is very much consistent and constant to the proportion of the dry muscle mass of the individual. That is, the muscle mass as a patient carry will be proportionate to the amount of creatinine produced each day. And this proportion is roughly estimated as 20 gram of skeletal muscle especially will produce around 1 milligram of creatinine. It is almost constant if this homeostasis is not influenced by some other factors. Again, the creatinine is very freely filtered by our glomerular filtered membrane. Almost 100% is freely filtered if not influenced by some other factors. That is why it has been taken. But here a drawback remains as well. As we know, all the creatinine not absolutely cleared or filtered by our glomerular filtration membrane. Very small amount of creatinine also secreted by our tubular epithelial cell. This part has not been taken here to calculate the renal function, especially of glomerular filtration rate. Again, some amount of creatinine also degraded by our gastrointestinal tract and easily excreted out through our stool matters. It also has not been considered here. Again, the creatinine that has already been filtered by our filtration membrane not absolutely reabsorbed by the tubular epithelial cell. That is 100% will be excreted out through the kidney. That is why it has been chosen, as it is very constantly produced by our body and constantly filtering by our filtration membrane. That is why it has been chosen as a marker of glomerular filtration rate measuring tools. But nowadays, there are some other markers as well available, and these are usually used to assess the renal function, especially of glomerular filtration rate, like cystatin C, a protein, 16 kilodalton C, protein kinase. It is more superior in comparison to assess the renal function than that of the creatinine, but it is not always available and not available everywhere. But it is now using in some Western countries and some developed institutes. Some other markers also available nowadays, like NGAL, neutrophil gelatinase associated lipocalin. Also, there is another marker is kidney injury marker KIM1, kidney injury marker, and another one is liver type fatty acid binding protein. Also, these are using in some of the research research study. So, as all these are not available, we are using the serum creatinine even then to assess the renal function.
আগেটুকু বলি, প্রথমে ধন্যবাদ দেই ডক্টর মারিয়াকে। সে সুন্দর এই রিদমে সে প্রেজেন্ট করেছে, ভালো লেগেছে আমার কাছে। তো যে তার ডিফেক্ট আমার কাছে মনে হলো যে প্রথমে আমরা সবার মাথায় কোশ্চেন ছিল কেন এই ফিমেল নিয়ে কাজ করবে কেন, এবং মারিয়া যেটা ডিসকাশনে দেখাইতেছে যে 21 নম্বর রেফারেন্সে আছে এই কথাটা। এটা কি আপনি ওই ইন্ট্রোডাকশনে ক্লিয়ারলি বলেছেন? ইন্ট্রোডাকশনে বলা উচিত এই রেফারেন্সের কথাটা।
স্যার এটা আমি ডিসকাশনে এনেছি।
ডিসকাশন না, আপনি কেন এই কাজটা করলাম, মানে অবজেক্টিভটা কেন? ইন্ট্রোডাকশন যদি এটা থাকে, মানে আমরা একটা স্টাডি করতে চাচ্ছি, কেন চাচ্ছি সেটা ইন্ট্রোডাকশন আসবে, এবং ইন্ট্রোডাকশনের শেষের দিকে আমাকে অবজেক্টিভ ঠিক করতে হবে। তাহলে আমি দেখতেছি যে ইন্ট্রোডাকশনে দেখা যাচ্ছে যে এরকম স্টাডি করা হচ্ছে, সেখানে ফিমেলদের বেলায় ক্রিয়েটিনিন বেশি বাড়ে, এই জন্য আমি এই স্টাডিটা করছি, সেটাই হলো অবজেক্টিভ। সেই ডিসকাশনে কি এস্টাবলিশ করা হয়েছে কিনা?
স্যার
ডিসকাশন না, ইয়েতে
ইন্ট্রোডাকশনে স্যার আমি হচ্ছে এখানে আমার তো স্টাডি গ্রুপে সেরাম ক্রিয়েটিন ওয়াজ ইনক্রিজড, বাট আই ওয়াজ
ইন্ট্রোডাকশনটা দেখান।
জি স্যার,
আপনি যে কাজটা করবেন সেটা ইন্ট্রোডাকশনেই ক্লিয়ারলি আসবে, এই জন্য আমি কাজটা করতেছি। ইন্ট্রোডাকশনের শেষের দিকে আমার অবজেক্টিভ হবে, একটা জেনারেল অবজেক্টিভ, একটা স্পেসিফিক অবজেক্টিভ। আমি যদি দেখে থাকি যে ইন্ট্রোডাকশন আপনি এটা লিখেছেন, তাইলে হবে।
স্যার এখানে ফিমেলের পরবর্তী ডিসকাশনের রেফারেন্সটা
না, ডিসকাশনটা পরে আসছে, কাজ করার পরে, কাজ করার আগে এটা ঠিক করতে হবে।
এটা কিন্তু
Sir, while doing the study, when I did the study, there were lots of parameters there. So one of the parameter is this one, and আমি এখানে একটা কোয়েশ্চেনিয়ার তৈরি করেছিলাম, তো এটা ইটস মাই ফল্ট, আই এম সরি যে আমাকে এটা অ্যাড করা উচিত ছিল, কিন্তু ওখানে আমার একটা হিস্ট্রি ছিল যে তার ফ্যামিলি হিস্ট্রি, তার ড্রাগ হিস্ট্রি এবং ফর হাউ লং হি অর শি হ্যাজ বিন ডায়াবেটিক, এটার একটা ইয়ে ছিল যেটা আসলে আমার এখানে অ্যাড করা হয় না, বাট ইন মাই থিসিস আই ডিড দ্যাট।
So creatinine লেভেলটা দেখানো হচ্ছে ফিমেলের 0.6 to 1.1, মানে এটা আমার কাছে যেটা মানে যে রিয়েজেন্ট কোম্পানি অনেক বহুত রিয়েজেন্ট কোম্পানি আছে, কিছুটা ভেরি করে অনেক সময় 1.2 আছে কোনটা। তো সেই ক্ষেত্রে at the age of 65 or 70 creatinine level 1.5, is it highly significant?
Thank you, sir, for your question.
In the protocol, research protocol, and also in the introduction and aims of the study. Maybe that may be the example. But my many suggestions to the speaker that you have lot of data still to be analysis. Number one is that you do not have any chart or any table for the duration of the diabetes.
Sir, about the duration of diabetes,
Well, listen to me. You may correlate with the creatinine value with the duration of the study. You put in one side the creatinine value because it's a single point study. So duration on one side and creatinine level in one side, and you can correlate with that. That may be a good analysis. Number one thing. Number two, probably you have shown that the BMI is raised
yes, sir.
in all the study groups.
Yes, sir.
The mean value is high, like 28 in both study group, but a bit lower in the
Control group.
control group. It is not comparable. Why? Because obesity or overweight may impair renal function. Yes.
Sir. Yes, sir.
যদি আমরা ওয়েট কমাই, ওবেসিটি কমাইতে পারি, ক্রিয়েটিনিন ভ্যালু কিন্তু কমে আসে। সো ইট ইজ নট এ লাইক টু লাইক কম্পারিজন।
Yes, sir.
Probably you have some data that the low BMI patient in the study group, so that you can compare or you can have some analysis on the low BMI group patient or normal BMI group patient, what happened to their creatinine in this study. Maybe, probably. So কারণ তোমার লাইক টু লাইক কম্পারিজন কিন্তু হয় না। 25 দিয়ে সাথে 28 অলমোস্ট 29, এটা কিন্তু কম্পারেবল হয় না।
Yes, sir.
কারণ ওবেসিটি কিন্তু ইম্পেয়ার করেই রেনাল ফাংশনকে। এটা আমাদের নেফ্রোলজি যিনি আছেন রিসোর্স পারসন, উনি কিন্তু এগ্রিড উইথ মি এটা। সো আরো অনেকগুলো চিন্তা করলে আরো কতগুলো সাবসেট পাওয়া যাবে। সো ইউ মে হ্যাভ অ্যানাদার অ্যানালাইসিস এন্ড অ্যানাদার
Another analysis.
paper with this study. There is very good reason to have another paper with this study. Okay, thank you very much for clearly present all these things. স্যার যে কোশ্চেনটা করলো ওইটাই বলা যায় ইয়েস, এই ক্রিয়েটিনিন নিয়ে এত ফ্যালাসি থাকার কারণে এখন কিন্তু ওয়ার্ল্ড ওয়াইড ফার্স্ট চান্স ইজ দ্য ইজিএফআর। এবং তুমি ইজিএফআর করতে পারো, ইজিএফআর করেও কিন্তু আলাদা একটা সাবসেট তৈরি করতে পারো যে এদের ইজিএফআর ক্রিয়েটিনিনের সাথে ইজিএফআর কি ছিল। কারণ আমার ক্রিয়েটিনিন কিন্তু আমার সিকেডি স্টেজিং এর পার্ট না,
না, sir. Yes, sir.
একেবারেই না। আমার সিকেডি স্টেজিং এর পার্ট কিন্তু ইজিএফআর। সো তুমি কিন্তু সিকেডি স্টেজিং করতে পারো ইজিএফআর দিয়ে এই পেশেন্টগুলো, যে তারা কোন স্টেজিং এ আছে। সো এই ক্ষেত্রে অনেকগুলো জিনিস করার কিন্তু তোমার অপরচুনিটি স্টিল ইউ হ্যাভ। এটা গেল। সো ইজিএফআর ইজ ওয়ার্ল্ড ওয়াইড দ্য বেস্ট প্যারামিটার ফর স্টেজিং সিকেডি। এটাই স্যার আসলে আমাদের এখন মেবি ও ইজিএফআর নিয়ে কেন করলো না, হয়তো ইজিএফআর নিয়ে অনেক স্টাডি আছে, সেই স্টাডিগুলো হয়তো আর পুনরাবৃত্তি না করে ক্রিয়েটিনিনটাই দেখার চেষ্টা করলো একটা সিঙ্গেল পয়েন্ট। কারণ স্যারও যেটা বললেন যে রিসোর্স কনস্ট্রেইন তো থাকেই, টাইম কনস্ট্রেইন থাকে, এটা একটা সিঙ্গেল প্যারামিটার নিয়ে দেখছে। তো ইজিএফআর দিয়ে কিন্তু আমরা সবকিছু করি, যার ফলে একটা এলডারলি পেশেন্ট থেকে শুরু করে সবার ক্ষেত্রেই কিন্তু পার্টিকুলারলি অ্যাডাল্ট পেশেন্টদের ক্ষেত্রে ইজিএফআর দিয়ে কিন্তু সিকেডির প্যারামিটার গুলো অ্যানালাইসিস করে। আর উনি তো বলেই দিয়েছেন যে আমাদের মাইক্রোঅ্যালবুমিন এটা হলো ফার্স্ট প্যারামিটার টু গেজ ফর দ্য ডায়াবেটিক নেফ্রোপ্যাথি। আর কিছু? থ্যাংক ইউ ভেরি মাচ।
By the absence of this estrogen hormone, and they are more vulnerable to develop significant renal impairment. So it is very much significant choice of the reproductive age group female patient as his stratification. But the design can be changed with some other.
For your excellent presentation. তো আমার ওখানে মেনোপজাল এস্ট্রোজেনকে অনেক দায়ী করতেছে, কিন্তু প্রেগনেন্সিতে স্কাই হাই এস্ট্রোজেন প্রতিষ্ঠা, তারপরে কিন্তু রেনাল ফেলিউর হচ্ছে, তাই না? এটার কারণ
Pregnancy is another physiological effect.
শুরু হইলো ক্রিয়েটিনিন দিয়া আমার কাছে একটা প্রেগন্যান্সি করোনা লাগে এখন আমরা চেয়ারম্যানের কাছে শুনতে চাই যে আমরা আসলে এটা কিন্তু অনেক শুনলাম প্যাথোলজি আমাদের ইন অ্যাসপেক্ট অফ ফিজিওলজি, মানে ম্যাডামের কিছু বলার আছে কিনা একটু জানতে চাই। ধন্যবাদ।
ডাক্তার ইউনুস ভাই, কারণ উনি আমাদেরকে অনেক হেল্প করছে। আমিনুল ভাই, তারপর আমার পাশে তো আমার রিসোর্স পার্সন না থাকেন, তো আমরা সবার সাথে করলাম যে আমাদের জ্ঞান করছে। আর আমাদের প্রিন্সিপাল স্যার আমাদেরকে পুরাটাই গাইড করে গেছে, সব কিছু করে গেছে, কিন্তু আজকে স্যার থাকতে পারে না, আমরা কোনো কারণ করছি, কিন্তু পুরা থিসিসটা স্যার আমাদের গাইড করে গেছে। থ্যাংক ইউ।